I have you with me now, I want to continue on the next topic, which is related to inpatient. And I think inpatient is an area of let's say debate in the market. Lots of questions around how the inpatient is. Currently, the system works on packages, as you know. Package is just a certain description with certain code from the provider, and comes with a full price. We don't know the details. It's a negotiated, the value is negotiated between the insurance and the provider, and the system is going on. Now we are saying, as a regulator, the market is going to move to DRG in the future. Meanwhile, we want to do some sort of a fee for service or not fee for service. We want to keep the package, but list the services under it at zero value. What exactly are we telling the market when it comes to inpatient, Mr. Abdullah?
Currently, Dr. Aham, you know that so far we did not adopt any kind of movement in this regard. But however, that our strategy and our roadmap to the value base is to move from the fee for services to the DRG. It could be basically next year or in the second half of this year, maybe, that we will launch our strategy in adopting the DRG. We will encourage the market to adopting. I think there is also incentive and motivation for those early adopters for the DRG. And as you said, that currently, if you will not do the pricing and do the proper mapping or any repricing your services to the CCHI system, that will also affect you when it comes to the DRG. The DRG is basically built on ACCI, and CCHI billing system is also built on ACCI. So in both ways, you should do now the pricing, and however, that when it comes to the DRG, definitely it will be based on the CCHI system, and eventually it will be also a part of your payment when it comes to the claims that you will be submitted to the insurance company. What is the current practice now? We also maybe, as I told you, maybe next half this year, we will maybe propose some kind of strategy. It will be in between the DRG and the current package deal, and we will see how the market will be react on that. But definitely will not interfere directly. We'll give a grace period, and also we're trying to target a pilot provider to adopt the DRG. Then when we will see that the market is mature, we will move to the DRG. And since we're talking about the DRG and all of the stuff and the coding and also all of this, Dr. Aham, just to highlight that from last year, we request all the providers and the payers to submit to us to the MDS, and part of the MDS is to measuring the maturity of the market. And so far, we see that there is a good maturity from the market. So hopefully, inshallah, at the end of the year, with the full of the code said that you have it now in your hand, you can do the coding properly, and then we can move to the DRG.
So, Mr. Abdullah, basically, if as a provider now, if I'm a provider, I should continue invoicing using the package. Mandatory, there's no mandate anyway on DRG, which I understand clearly. But do I need to code the services under the package and report it to CCHI on the fees, or not yet? It's not mandatory, but it's just recommended from you.
Yes, great, Dr. Aham. Especially for those in wave one, and they been, I think, onboarded in the fees, and they been communicated how they should do the shadow billing when it comes to the package deal. There's some certain requirements for them. We don't want to interrupt the market with saying there should be shadow billing and listed all the services with their prices. But when it comes to fees, there's some guidelines and direction. For those providers in wave one, they should clearly know that. If they not, please communicate onboarding, and they will guide you on that.
Yeah, this is clear, and I completely agree with you also on your recommendation, regardless whether there is mandate or not, for providers to start coding those services, because for them to know their cost and move to DRG, it's important for them to know the details of each and every package.
True.
Okay, Mr. Abdullah, thank you for your comments. I will get back to you, but I'm going to go now to Noura and to talk a little bit about packages versus fee-for-service, and using an example on how they differ, and what would that be the impact from a coding point of view.
Okay. Let me start by emphasizing on what Mr. Abdullah had just said. The CCHI is requesting the providers to provide them with fee-for-service against each and every package. But just to make it easier for the market right now, they are asking them to just bill it with the price against this package. In this example, we have a dental procedure. It's a very common procedure. It is the facial abscess. One is under local anesthesia, and the other one is under the general anesthesia. And as you can see here, it's a straightforward, very easy example. We have one for 3,500 riyals, and the other one is for 15,000 riyals, where the length of stay for 2 days. If I am sitting in the under a healthcare provider and I want to map this, maybe a coder will think that, okay, I will take the description of the code, which is the facial abscess, and I will add either one of the two codes, either general anesthesia or the local anesthesia, and I will be done. Well, actually, it's more complicated than this, and I will take you to more details in the next example. I have started with the day case scenario. Under the day case scenario, if we can go to the next slide, please. Under the day case scenario, when we are mapping the service, we have to map it to the consultation. We have to map it also to the local anesthesia. The room charges, which is the day stay, the procedure charges, and the OT room charges. In addition to that, we have to add the lab and drugs and consumables that are being used here. The quantity of each one of these is 1 because the consultation is happening only once. The room charges is once. All of these cases is being mapped to a different code. This particular procedure is being mapped to a different codes, which are the components of my package for this day case. Now, if I will go to the next slide, where we are having this procedure under the 2-day stay. In addition to the consultation, I have a rounding fee. The rounding fee is, as you know, is the consultation where the specialist is visiting the patient while during his stay in the hospital. I didn't add a quantity there because it depends on the number of visits that this specialist has done to this particular patient. I have to add it there. The room charges has changed. The quantity is 2 because now the patient is staying for 2 days. The procedure charges is the same as we have agreed previously. Now the anesthesia is changed to general anesthesia code, and the price will be changing as well. The OT room charges, we have to bill it against the operating room for complex procedure or surgery. So now my code is different, and the way that I'm billing for this particular code is every 30 minutes. So if my procedure took me 30 minutes, I will have the quantity 1. If it is more than 30 minutes, each 30 minutes will add 1 quantity to my billing. So it will be multiplied by 2 or 3, depending on the length of the procedure that is being done. In addition to that, we have the lab and the drugs to be added to my claim. So based on this example, we can see that the price that is being done here, or the price that is being given here, is 15,800. When I'm doing the billing now under the current situation, I have to put my package name under the procedure charges, and then I will have to list down all of these services, and I will put only the price under the 15,000. When we are moving to DRG, we will have the DRG code against it, and we will have the price based on the discussion with the insurance companies. and the multipliers, etc. It's very important to note that the way I'm pricing my OT room charges, the anesthesia for general or local, the rounding fees, all of these will add to my claim, and it should add up to reach to the 15,000 reals as well. The complexity of the procedure and the length of stay here had an impact on the way that I'm billing this particular service to the insurance companies.
Thank you, Noura, for this. I have a question, because you and me and Eileen were talking about this before we started the webinar. When we move to CCHI, we do not require to get, when we move to DRG, we do not require all of this to get a DRG. We require the description, the diagnosis basically, and the key procedures from the ACCUMED system. First of all, I received a question about whether we should use ACCUMED or CCHI billing system. CCHI billing system is based on ACCUMED, and all the ACCUMED codes are embedded, so you could use the CCHI billing system as one unified platform for both your inpatient, outpatient, and DRG coding. Just to answer that question. Now, going back to this question, why do you ask me as a provider now to list all of this and look at lab and drugs and consultation? And it's a hectic one. DRG is much simpler. Why would I have to do all of this?
As Mr. Abdullah was saying previously, if any regulator in any market wants to have a proper DRG presented to the market, they need to know the components of each and every procedure. Therefore, they are asking us to break down these packages that are being billed to the insurance companies, because now we have a package which is saying that facial abscess under general anesthesia. So we don't know what the provider is putting under these under this particular procedure. There might be different lab services for each provider that the doctor might ask for his patient. We might have different drugs. We might have this provider might do this procedure within 30 minutes. The other might do it within 60 minutes. The rounding fees might change. This provider will have like 3 rounding fees during this stay. The other might have 5. A different provider might have 1. So if I want to have to present a DRG to the market that will not have will be based on an informative decision, I need to see to collect as much data as possible based on the fee for service, the services that are actually being provided to these patients, for me to build my DRG around them. Because as you know, all DRGs will give you a base rate. So for me to give the proper base rate, I need to have this data present in my database to do the studies on all of these services and all of these costs. This provider might have this package under 15,000. Other provider will have it under 25. A different provider will have it under 9. So I need to have this data to compile all of these components and reach to my DRGs and build my DRGs based on that and give the base rate based on this particular data and the prices that I'm seeing in the market, the quantity of services, the utilization of these services, how many times I'm utilizing the rounding fees, how many times I'm utilizing the consultation. All of these things should be part of it, because as you said, once the DRG is implemented, we will not see those services anymore. We will have only the DRG code and the price next to it. So for the CCHI to be able to take an informative decision, I believe they are doing it the right way when they are asking the providers to show the components for these packages. Yes, it will be hectic. Yes, it will require more work for the providers, but it will help them to reach to a very fair base rate when we implement the DRG in the future.
I think I want to continue on this and ask you a little bit, maybe 2 points. You have been there when, if we want to take other markets experience, especially UAE, because you're based in UAE, and you've been there when Abu Dhabi moved to DRG. You are now dealing with providers while they are moving to DRG in Dubai. First of all, when calculation of base rates, from your experience, what did the regulator depend on?
Actually, the most recent experience we have is here in Dubai, where we have recently moved to the DRG. Being part of the task force for DRG ACCUMED as a part of the task force for the DRG implementation in Dubai, we have went through a lot of discussions with the insurance companies, with the regulator, about the data that they are taking into consideration. For example, at the beginning, they were taking the paid amount from the payers to the providers, regardless of what is the claimed amount from the providers. They didn't take into consideration the consumables. Then later on, based on the discussions and based on the data that was shown in the workshops, the regulator took into consideration the claimed amount by the provider, because some of the claims are being rejected from payers. They took into consideration the paid amount. They took into consideration the consumables, the high value consumables, like when we are having a knee replacement or a hip replacement. This kind of consumables cannot be billed under the DRG because the price of the consumable itself is very high. So these should be billed separately, not under the DRG itself. In other cases, no, we have all the services, which includes the consultation, rounding fees, room charges, everything falls under the DRG itself, where we have a base rate for the DRG. Insurance and the providers are discussing, or they have already discussed having a multiplier. It is the multiplier is between 1 to 3, based on the data which was collected during this period. They took the data for 2 years, basically, and it is up to the provider and payer to agree on a multiplier. But the provider will know what is their nil impact factor. Let's say I have a provider whose his net impact is factor 2. So we can't go under factor 2, otherwise we will have a negative impact on our revenue. Or we are trying also to negotiate with the insurance companies to get more than or higher factor for our providers, or the provider is negotiating to get the higher factor for them to get better revenue from these. The length of stay is very important component for DRG, because whenever we are presenting a DRG to the market, we give them the DRG is being presented there along with the length of stay expected. So we have some providers who used to keep some patients longer than the requirement of the procedure that was done. Now the length of stay is getting less based on the DRG, because keeping this patient longer, it won't help me to make more money anymore, for example.
Okay, thank you, Noura. Very useful and comprehensive. I'm cautious of time, but just in 1 minute, based on all of these transformations you have seen, what do you advise providers, people who are listening to us now, they know the DRG is coming, what should they do to be prepared in a year or two?
The first thing is that to build all the components of their procedures, to train their doctors to do proper documentation, because the billing of these procedures and will be based on the documentation of their doctors. The pricing to be put properly against fee for service, and to have their cost calculated, even if now it's not possible. Again, I know I'm repeating myself, but it's really important to know my micro cost and my macro cost, and based on that to have the study ready to be presented to the insurance companies and to take it forward with them.
Thank you, Noura. Eileen, any thoughts before we move to the next point around this inpatient topic, packages, DRG? You are in Australia. You guys have been using DRG for years and years now. So any thoughts which you might tell the market from your experience?
Yeah, I think, Noura's probably covered most of it there, but I think it's really important to consider this as the ownership must come from, your executive team, your billing team, your revenue management teams, your coding teams, but importantly, the engagement in this process needs to also come from your clinical staff, because at the end of the day, this process is being implemented to drive value-based healthcare, to improve health outcomes for the population, to drive quality healthcare. So they're all really important factors, and everybody needs to be part of the process. It shouldn't just be coding, it shouldn't just be clinical, it shouldn't just be the executive. It needs to be a team approach, and everybody involved in that process, because you'll all have certain skill sets that contribute to this. So, and to remember that things, you will go back, you'll correct some of your mapping. It may be wrong the first time, and you'll go back and you'll correct it, and you'll make changes, and you'll modify as you go. And this is a changing, ever evolving process. So the work doesn't end. And I think, just coming to terms with that is important. So setting up your task force, setting up your meetings, setting up those sorts of teams that will be involved in this process collectively is important, and it's ongoing. So, and I'm sure most hospitals will have started that process already, but to really sort of engage with it and ensure that everyone's on board, because once you start getting the momentum going, you'll continue to refine the process over time. And no process is perfect. Australia isn't perfect. We're still refining processes as you move along the journey. Medical technology changes, so it's that constant adaptation to the world. We've had to change classifications to include COVID diagnoses, etc. So there's all of those sorts of things that is a constant evolution. So it's important that you set yourself up for success and ensure that there's a whole team approach to this, because unfortunately it is changing, and everyone has to sort of move along that process. And you can't stay and try and translate the old ways of doing things into the new ways. Sometimes you have to be adaptable and pivot to ensure that you can meet the requirements going forward. So I think changing that sort of that shift is important.
So thank you, Eileen.